I do hope that we can further work and collaborate more in academic sessions like this. So today I've been tasked to talk about intersphincteric resections, I don't have anything to disclaim. Now, the outline of my talk will mainly be on the evolution of how this developed, the anatomy, which is very important in this surgery, patient selections, and the actual surgery itself. And of course, very important for the oncology surgeon is the oncology outcome and the functional outcomes. Now, I do understand that we have the very esteemed Prof. Kim, who will be talking immediately after me, and he will obviously further illustrate and talk about his experience, I hope that we can all learn and share from these two talks. Now, a little bit about cancer, colorectal cancer in my part of the world, particularly in my country. Colorectal cancer is the second most common cancer, but the most common cancer in men and second in women. And the lifetime risk is 1 in 56 in all males and 1 in 74 for all females. Now, the trouble is in my country, we don't have a national screening program. So a majority, or at least 2/3 or more, present at stage 3 and stage 4. And out of these, 75 to 80% are on the left side and in the rectum. Now, what we found in our study was that in patients who underwent long-course chemoradiotherapy, a significant amount of them do not come back for definitive surgery, primarily because nobody wanted a permanent stoma. So the role of an intersphincteric resection in a selective group of patients would be truly beneficial in trying to reduce this rate of defaulters after chemo radiotherapy. Now, as we all know, in 1908, Miles first described the APR with a permanent stoma, but it was in the 1940s when Dixon first described anastomosing the rectum to the colon with a hand-sewn anastomosis. Now, obviously, with technology now, we're going lower and lower. And but the real, I'm sure you all know, but the real difference was described by Bill Hill when he described the total mesorectal excision with excision of the total mesorectal with a TME plane. Now, for intersphincteric resections, Sichel et al. And his colleagues described in a 1994 paper about removing the internal sphincters in 38 patients with very good outcomes and satisfactory continence in their series. Now, there are various definitions of ISR, and I like this particular definition, which states that ISR is a specialized procedure involving a hand-sewn coloanal anastomosis accompanied by some degree of internal sphincter resection and without the use of a mechanical anastomosis. Now, obviously, in our next talk, Prof. Kim will be talking about the Delphi consensus, which has very well come with a consensus on the definitions of intersphincteric resections, and that will make the definitions and the descriptions of the anatomy much easier. And I look forward for the talk after this. So very quickly on the anatomy, a lot of colorectal surgeons describe the intersphincteric resection is really between the sphincter, the space between the internal and external sphincters. But studies by our Japanese colleagues looking at cadaveric specimens, they look at the sphincter complex right down below, and if you look at the posterior aspects of it, what they found was that the internal anal sphincter and the longitudinal muscles are really very closely adhered, and that the intersphincteric space, to access the intersphincteric space, which is between the internal lining of the longitudinal muscles and the the internal lining of the longitudinal muscles and the external anal sphincter, you actually have to go through something called the hiatal ligament, which colorectal surgeons previously called the rectococcygeal muscle. And that's the only way really you can get into this space. I'd like to share this slide by my good friend Professor Ito from Japan, which describe these two main structures which are needed once you have completed the TME plane all the way to the pelvic floor. And to access the internal, the intersphincteric space, you would have to go through the rectococcygeal muscle, or currently known as the hiatal ligament, and the rectourethral muscles. So this is the levator ani muscles, which we all know, and this is the hiatal ligament, which we have to go through to enter that space, right? And anteriorly is the rectourethral space. Now, this is a video that I did a couple of years ago, illustrating this anatomy. So you've gone all the way down, and now we're starting the intersphincteric resection, and that is the pubococcygeal muscle. And here is the hiatal ligament, or the rectococcygeal, or some people call it the anococcygeal muscles. And you have to cut into this to enter the intersphincteric space posteriorly. So here you have the intersphincteric plane, and you have the puborectalis muscles clearly shown. And anteriorly, you have the rectourethral muscles, which you would need to clearly define, and be careful not to injure the cavernous nerves and the urethra above. Then, of course, once you have completed that phase, then you have to go through the perineal phase, which involves creating a purse string suture posteriorly, through the anus, and then cutting through the mucosa and reaching the plane of dissection, which was achieved transabdominally earlier. Sorry. Right. Now, in terms of the patient selection, now there's a lot of studies and systematic reviews that have been done. And you can see here that depending on the authors, the distance from the anal verge may vary from as little as 15 millimeters to about 50 millimeters. And generally the T stage of the tumors are from T1 to T3. Now, but I think it's safe to say that the tumors that are located within 5 centimeters from the anal verge, which are mobile, and patients who have good anal function, and the tumor obviously cannot be a T4 tumor that invades into the external sphincter, then these are the patients that you would probably choose to undergo intersphincteric resections. However, if the tumor, as I mentioned, it invades the external sphincter, or if the tumor is fixed, or has very poor histology, like a polydifferentiated carcinoma, or if the patient has to begin with poor anal function, then these patients may not do too well and are not suitable candidates for intersphincteric resection. This is very important, the workup for these patients. So all patients obviously will start with a digital rectal examination on presentation prior to chemoradiotherapy and after chemoradiotherapy. And so obviously the standard is performing an MRI. An endorectal ultrasound is very operator dependent, and I don't use it particularly for this purpose. So I would be very dependent on my MRI and my digital rectal examination. And what I'll be looking for is the tumor height, the evidence of original lymph nodes, and the T staging. Now, when you talk about intersphincteric resections and how much internal sphincters you are cutting would determine whether it is a partial ISR, a subtotal ISR, or a total ISR. And if the tumor is above the levator ani, and then you can safely do an ultra-low anterior resection, which is not an ISR. But once the tumor invades the external sphincter, then these patients are not suitable candidates, and you would probably do a abdominal perineal resection. Now, what are the surgical outcomes? I think most importantly, let's look at the immediate outcomes in terms of the complication rates. The most common complications would be anastomotic leakage and stenosis due to a very, very low anastomosis. In terms of oncological outcomes, the RO resection rates are relatively good. And the disease-free 5-year survivals and overall 5-year survivals are also comparable to an APR. So all these studies do show that the local recurrence and overall survivals are comparable to an APR. Now, as a colorectal surgeon, one of the concerns is when you're anastomosing so low down, what is the functional outcomes? And what they found was that at 1 year after stoma closure, at least, the maximum resting pressure reduces but improves over time. But the squeeze pressure is not affected because you are actually preserving the external sphincter. And similarly, these studies also show similar outcomes, even though there's a drop in the resting anal pressure following ISR. The squeeze pressures actually do recover to preoperative levels after 12 months. Now, when they look at what are the factors affecting functional outcomes, one of them is age, but the other is obviously the amount of internal sphincters that is resected and the fact of whether the patient had preoperative chemoradiotherapy prior to surgery. So the factors affecting functional outcomes are really age, radiotherapy, the length of the internal sphincter excised, and the fact that whether the patient had a coloanal straight or pouch anastomosis. Now, in summary, it is a feasible and viable option, but I must emphasize that proper patient selection is of the utmost importance. You probably shouldn't be doing it if you're just starting out doing a TME surgery, and leave it to the more experienced surgeons. Now, studies have shown that the oncological outcomes are very comparable, but the functional outcomes, if surgery is done properly, patients will suffer a little bit of some degree of incontinence, but the studies have shown that this improves with time. More importantly, I think that these patients need to go adequate preoperative counseling to set expectations. So thank you very much. And before I end, I'd like to greet you all. This is the Malaysian Society of Colorectal Surgeons. So Malaysia is a country of about 35 million, and we have about less than 100 colorectal surgeons. And as you can see, because colorectal cancer is probably the most common cancer in Malaysia among men, so we have our work cut out for us. And this is where we are. We're next to Singapore, Thailand, and Indonesia. And I'd like to invite you all, if you have the time, in 2025 to attend the Asia Pacific Federation of Coloproctology meeting, which will be held in the east of Malaysia, in a very beautiful place called Kota Kinabalu. Thank you very much.
Thank you so much, Dr. Maslan, and thank you so much for your kind invitation. I think it was a wonderful lecture. I think we are going to have the questions by the end of the session. We can move on to the next lecture with Professor Sonan Kim. I would like to introduce, I think Professor Sonan Kim, he doesn't need an introduction, but it's just a part. He was the past chairman of the Korean Society of Endoscopic and Laparoscopic Surgery, past chairman of the Department of Colorectal Surgery and Anam Hospital, and he's actually professor of the University of Malayan Medical Center in Kuala Lumpur, Malaysia. Thank you so much, Prof, for joining us, and you can start your lecture. He's going to talk about his Delphi consensus about intersphincter resection.
Thank you, Dr. Hugo. Very nice to see you again. I'm just sharing my slide first. Yes, this is my great honor and pleasure to participate in this webinar. Thank you for the invitation. I'm going to talk about debate and also consensus, which I have obtained during my researches for intersphincter resection for the last few years. Yes, as introduced, I had worked at Korea University Annam Hospital for many years. Then I moved to Kuala Lumpur, Malaysia, 2 years ago. These are my new working hospital, University of Malaya Medical Center, and new colleagues. And also, I'm traveling Southeast Asia and Australia for robotic surgery proctoring after I moved here. And I have no COI for this particular talk, and to deliver my talk more clearly, the rest of slides are voice pre-recorded.
Intersphincter resection was first introduced in English literature in 1994 by Professor Shisel. 3 years later, Professor Masahiko Watanabe Group from Japan reported the same concept of procedure performed in a per-anal approach. Although this operation was introduced almost 3 decades ago, only a limited group of surgeons in a few countries are practicing this procedure with enthusiasm. What is the reason for such a limited practice? These are the primary issues. What is the optimal technique? How is the anal function? And perhaps most importantly, what about the long-term safety? As such, ISR is often viewed as oncologically not safe as APR. During the last 3 years, our group has had a special interest in ISR through several publications, including a review of oncological safety, a risk factor analysis for local recurrence and survival, review of anatomy and surgical techniques, search for technical controversies, and video demonstration of anatomic landmarks for transabdominal intersphincteric dissection. What have we recognized and learned from these researches? Firstly, we found that long-term oncological safety has been largely demonstrated, as summarized in this busy table. Compared to APR, oncologic safety has also been demonstrated in several studies. However, there are diverse opinions on the definition of ISR. Actually, each article had its own definition. Study on the anal function is yet limited in number and quality. There is little, even no consensus on the proper indication, and surgical technique has not been standardized. Fundamentally, ISR requires 2 distinct phases of dissection, abdominal and perineal, and 2 different approaches were introduced, abdominal first and per-anal first approach. My own ISR technique is the abdominal first approach. On the left-hand side, you can see Da Vinci Xi operation, and the right-hand side is Da Vinci SP operation. Division of the anococcygeal ligament posteriorly is often the first step to get into the intersphincteric plane. Then both lateral sides of the lower rectum and the upper anus are dissected off from the levator ani and the external sphincters. Identification of the correct plane is facilitated by electric stimulation on the external sphincters. Once the recto-urethralis muscle in male or the perineal body in female is exposed anteriorly, it should be carefully divided, Then I moved down to the anus. After inserting a gauze into the anus, then injecting epinephrine solution, a circumferential incision is made on the anal mucosa, deep to the internal sphincter at the dentate line. The external sphincter is usually seen as a whitish tissue. The dissection continues in cephalad direction through the intersphincteric plane. The distal lumen is occluded by sutures to prevent any risk of cancer cell spillage. Once the two dissections, abdominal and anal, have a rendezvous, the specimen is retrieved through the anus. After copious irrigation, a hands-on side-to-end anastomosis is done.
This is an example of how the ISL specimen looks like. Another specimen. And actually, this is one major advantage of the abdominal first approach in my practice. Some patients initially anticipated to require ISL may ultimately finish with ultra-low entry section with avoiding per-anal dissection. A few months ago, we published a Delphi study that has 3-round survey for 6 topics, including 37 descriptive statements asked for agreement or not. Thankfully, 29 experts from 11 countries in Asia, Europe, and United States joined the study.
This study aims to standardize the definition related to ISL to develop a flowchart for decision-making between ISL, ultra-low entry section, and APL to create an international consensus on several key aspects of ISL and to better define low rectal cancers that invade the anus. These are the 6 topics questioned: anatomy definition, definition of ISL, indication, surgical technique, specimen description, and functional outcome. In this presentation, I want to show only some interesting data that we have obtained. In terms of anatomy definition, there was a high agreement for the anal verge, recto-urethral muscle, perineal body, and the intersphincteric plane. However, the anococcygeal ligament and the hiatal ligament were much debatable. For the definition of ISL, 100% agreement was achieved at the second round. One particular description was that the anastomosis is always hands-on. In contrary to ISL, ultra-low entry section had many different opinions because a variety of new techniques had been developed in the last decade for rectal transection and for anastomosis. But in this survey, the bottom line was that ultra-low entry section and ISL are 2 different techniques. Only 84% agreed with this definition even at the last round. Actually, some experts believed that certain cases of ultra-low entry resection can be considered ISR under the name of transabdominal ISR. Before moving to the next issue, indication, I would like to show this illustration first. The red-lined globular shape shows a T3 tumor extending to the perirectal fat. And if the extension is even reached down to the intersphincteric plane, as seen here, it is still T3 according to the current TNM staging system. So, in order to make the staging system more accurate regarding to the ISP involvement issue, we proposed this statement. A suffix ISP should be added in cases of ISP involvement, T3 ISP, and it achieved 80% agreement. This illustration schematically demonstrates the indication criteria for ISR that we proposed. T1 or 2, T3 not invading intersphincteric plane, and even T4 above the levator ani but not invading the ISP. And AP resection should be considered for T3 ISP or T4 extending through ISP to the levator or external sphincters. The agreement rate was about 85% at the second round. I want to show the video of this particular case today. If rectal cancer invades the recto-urethralis muscle, it is almost impossible to save the anus because of its proximity to the anus in anatomy.
A complete dissection of the prostate and transection of the membranous urethra below the prostate apex, the recto-urethralis muscle area was visible, and the intersphincteric dissection plane was easy to access. Further dissection of the intersphincteric plane was performed between the rectal longitudinal muscle and the external anal sphincter. This is the final view after a transabdominal dissection and left lateral pelvic node dissection. The perineal approach was then performed. The anal canal was dissected at the dentate line as for a partial intersphincteric resection. The dissection into the intersphincteric plane was easy due to the advanced transabdominal dissection. The large specimen size did not allow specimen extraction via transanal route.
Let's move to the surgical technique issue, abdominal first versus perineal first approach. The abdominal first approach should be the standard in case of preoperative suspicion of abdominal metastatic or locally infiltrative disease T4A or B because it provides early abdominal exploration. Interestingly, this statement achieved less than half of agreement at the first round, but close to 90% at the second round. Regarding the safe distal margin, the first round was an open question, and the reply was 10 mm in 1/3 and 5 mm in another 1/3. Based on this, we proposed a description: 10 mm distal margin should be generally aimed. However, a final 5 mm can be considered adequate. In case of shorter than 5 mm, further treatment should be considered. But half of the experts did not agree to this statement, and it was unlikely to achieve a united opinion. Lastly, functional outcome. For the anal function, 80% agreed that functional tests should be done routinely pre- and postoperatively. Choice of the test could be determined by surgeon or center preference, but for uniform data analysis, Wexner's score is preferred. LAS score should also be considered. Actually, anal function after ISR is in the center of question. This is one of the few studies on the functional outcome. In this Japanese study, the total LAS score was not different between ultra-low entry resection with stapled anastomosis and intersphincteric resection with hands-on anastomosis, even though
the incontinence score was poorer in ISR.
For summary, I would like to show this slide first. ISR is an anatomy-oriented surgery that does not compromise oncological outcome. It is also function-preserving surgery, but the outcome could be technique-dependent. How can I say like that? This systemic review shows very variable anal function data between papers. For example, the rate of perfect continence was ranged from 30 to 86%, and Professor Schiesel's data was the best. This is that paper, so I asked him personally when I was invited to his house in Vienna about 10 years ago, "What is your secret to have such an excellent anal function data?" He answered, actually taught me about his two particular techniques. First, use of a small-sized anal retractor as minimally as possible during per-anal dissection. The second was more interesting to me at the time. He recommended to have at least 4 quadrant stitches through the external sphincters during anastomosis, as seen in my video. This technique can reduce the risk of prolapse complications.
Neorectal colonic prolapse is a well-known complication after ISR. These two photos were taken from my own patients. When we reported this unusual type of side limb full thickness prolapse after ISR, we also conducted a literature review of the prolapse complication. Again, colonic neorectal prolapse was a well-known complication reported from various centers, including 12 cases from Yves Penis, France, and 33 cases from Professor Masaki Ito, Japan. Dear faculties and audiences, I would like to finish my talk with this second summary slide. There is little consensus yet on the proper indication, but if properly selected and adequately performed, ISR is a valid alternative to AP resection. I hope that our Delphi study offers valuable perspectives for our future practice and researches on this challenging but still debatable operation. Thank you very much for your attention.
Thank you so much, Prof. Thank you. Wonderful presentation. We are going to move to the final lecture. Unfortunately, Dr. Marks, he's traveling to India, so he's not going to join us, but he already sent a pre-recorded video. I will share.
It's a real
I will play the video.
good day, everyone, and thank you for inviting me to join this august group. You know, it's a real pleasure to be talking about one of my great passions, which is sphincter preservation for low-lying rectal cancer, and it's great that you're having a meeting on intersphincteric surgery, which we talked about as the TATA, the transanal abdominal transanal proctosigmoidectomy. And what I'm going to share with you today is our long-term oncologic outcomes for low rectal cancer after neoadjuvant therapy. And it's my great pleasure to do this against the backdrop of this watercolor of our hometown of Philadelphia, which is a watercolor from my father and mentor, Dr. Gerald Marks, who was the originator of the TATA. He was the first to ever do a intersphincteric resection after radiation therapy. And of course, the people on this in this meeting are fantastic, and I'm honored to be part of them, as well as my dear friend and mentor who needs no introduction, Sunhan Kim, and then our Mexican collaborators who are putting on this whole thing, Dr. Pilar, and of course Dr. Vela is a dear friend as well. And so I hope you'll like what we have to say. This data, by the way, was presented this past spring at the American Society of Colorectal Surgery and is set for publication in the Disease of Colon Rectum, I think in the March issue. So here are my disclosures. I'll basically talk to anyone who wants to speak with me. And, the background is that low rectal cancer after neoadjuvant therapy is a result of the poor oncologic outcomes and high morbidity and mortality that existed early and to the end of the 20th century. In 1984, Dr. Gerald Marks proposed this operation, which we're showing here, which is starting the operation at the anorectal ring to give a known distal margin, expand sphincter preservation, and also has the added benefit of doing the most difficult part of the operation first. So this is an operation that's really reserved for cancers only in the distal third of the rectum. This is what it looks like when you freed it up totally, and then we oversew it in a complete watertight fashion so there's no leakage or spillage of cancer or fecal matter, which was the problem I think that was encountered with the Norwegian trial, which is why they stopped the TATI cases there. The first minimally invasive procedure I performed in 1996 doing the TATI. So, if we look historically at what's going on with rectal cancer, somewhere between 40 and 60% of people in America still undergo APRs with rectal cancers. And so we thought we'd evaluate our long-term data and share with everyone in terms of how the TATA did. And it was our hypothesis that this would yield excellent results in survival. So to do this, we looked at a prospective database. We found patients undergoing TATAs from 98 to 21, because that's when we started really doing chemoradiation therapy. These were all cancers in the distal third of the rectum and after neoadjuvant therapy. So these are basically cancers under the first valve. So people who had metastatic disease or recurrent cancer or weren't treated with radiation therapy were not part of this study. And so for this period of time of low rectal cancers, we had 321 patients. We excluded the patients as stated. This left us with 255 patients, and they represent the focus of this study. So the main outcomes were the rate of distant metastases and local recurrence, as well as the patterns of metastases and disease-free survival. So of these 255 patients, 2/3 of the patients were men with narrow middle pelvis. 50% of the patients were SA3 with a mean BMI of 27, and 26% of the patients had BMIs of greater than 30. This was staged on presentation. And the mean level of the cancer was 1.2 centimeters. 71% of the lesions were inferior to 2 centimeters. The mean size was 4.8 centimeters, ranging from 1.5 to 16 centimeters in size, and this is where they were located. Now, when you look at a cancer like this, these are what we're talking about. These are tumors that are almost uniformly treated with abdominal peritoneal resections, and this is really an unfavorable group of patients. 2/3 were men, all were low-lying, half of them had positive lymph nodes, a quarter of them had size greater than 5 centimeters, and a quarter of them were overweight significantly. All patients received chemoradiation to a mean dose of 5,400 centigrade. And then the decision regarding sphincter preservation based on the cancer after 8 to 10 weeks of completion of the neoadjuvant therapy. This was done in an effort to maximize the tumor downstaging and the benefit that comes from this. And sphincter preservation was carried out for all patients except those whose cancer remained fixed in the distal third of the rectum or had sphincter involvement on MRI after completion of chemoradiation. So the 3/4 of patients had a good to excellent response, a quarter didn't. And this is how we approach these things surgically. 90% of these were done MIS, and we had no conversions and no rectal perforations. So this is what we saw pathologically on resection. There was significant downstaging. A quarter of these patients had complete response, no pathologic residual, and 30% of them still had stage 3 disease at completion. So, it should be noted that we do have a category of watch and wait. These were patients who clinically who were resected, or patients who had lesions you wouldn't feel comfortable not operating on. So we look at the TME, we only had 2.3% of the patients had incomplete TMEs. There were no positive distal margins, which is a beauty of starting the operation transanally, and only one radial margin was positive. 96.6% of the patients had near complete to complete TMEs. And this is what we're talking about. This is the distal margin. This is what we're looking at in terms of the TME. And when you look at this, it's impossible to get a GIA or a TA staple distal to this and not you'd be putting it across here. And this is why we start things transanally. 95% of the patients ultimately were stoma-free. We had no periocular mortalities. We had what one would expect in terms of morbidity with anastomotic leaks, ischemia, and abscesses. Overall, distal metastatic rate was 21.5%. The local recurrence rate of 5.1%. This is with a full 5-year follow-up, mean of 55.4 months. The average time to local recurrence was 2.5 years. So I think that we should be mindful of this as we're looking at things and trying to look at things shorter and shorter. Over half of our recurrences were more than 2.5 years. 2.4% was our isolated rate, and with the 2.7% of patients had metastatic disease. So half of our local recurrences recurred with metastatic disease as well. And when we looked at the distal metastatic, almost 80% of them were solitary mets, 21% were multiple sites, as shown here, liver and lung and bone involved. And looking at our overall survival rate, we had a very good survival of 84.5%, with disease-free survival of 78%. And all this together leads us to conclude that the long-term disease-free and stoma-free rates are excellent after TATA, and these are done in very low untreatable rectal cancers. The main sites of metastases are the liver and lung, as one would expect, and the favorable oncologic outcomes were durable over time. So, obviously we're going to look at other things to identify distal metastases, and this is what has led to the embrace of neoadjuvant chemotherapy or induction chemotherapy, see if we can decrease this in the future. These are the key components in expanding sphincter preservation, basing your decision on sphincter preservation on the cancer after completion of chemoradiation, and offering sphincter preservation on all patients unless they're fixed in the distal third of the rectum. Obviously, there's still a lot of work to be done. We look forward to working with this august group to do that. And again, thank you for your interest, and hopefully I'll be able to be on to take some questions, but I'm traveling and I'm not sure if that's going to be possible. So Best of luck. Have a great rest of the meeting. I look forward to us all being together in person. Thank you.
I think this is the end of the lecture. We're going to start with the panel discussion. Dr. Jorge, if you want to start with this reflection about intersection from your point of view.
Ok, gracias Hugo por la invitación. Saludos a los panelistas. Varios puntos. Las charlas, por los que más lo saben hacer, expertos, pero varios puntos. Es una cirugía oncológicamente segura, es una cirugía selectiva, pero es una cirugía que tiene una característica que es lo que nosotros los cirujanos latinoamericanos nos debemos llevar. Una segura que asegura margen de sección distal. Y esta es la verdadera razón por la cual esta cirugía subsiste. Si usted me preguntaría cuál es el nombre correcto, siempre he pensado que la cirugía ultrabaja interesfintérica deberíamos llamar cirugía de preservación parcial de esfínteres, porque bien o mal, si hacemos la cirugía tal cual nos la mostraron en los videos, es una cirugía donde sí hay una pérdida parcial del esfínter interno y por eso tiene unas implicaciones funcionales en muchos de los pacientes. Por tanto, esta cirugía hoy, como reflexión para decir, hoy en día es el producto probablemente de un caso que preoperatoriamente se intentó la preservación de órgano y no se llevó a cabo. Por tanto, el diagnóstico anatómico de la lesión es tal vez el punto más importante y es un diagnóstico basado en examen físico, clínico, tacto, resonancia magnética con unas características que después podríamos hablar y definir desde el comienzo, inclusive antes del inicio de la terapia neoadyuvante total, si este es un candidato factible como las indicaciones que nos dieron a una resección interesfintérica. Y si lo es en el control después de del TNT, que no hizo preservación de órgano, es muy importante saber la localización del tumor para que la cirugía sea correcta. La ventaja, el cilindro sale completo, se mantienen los principios oncológicos, decisión total del mesorrecto y sobre todo se asegura claramente el margen de resección distal, que es la razón de ser de este tipo de cirugías.
Excellent. Thank you so much. We can move to Dr. Itzel Vela. Doctor, do you have any reflections, some comments to the speakers about the intersphincteric resection? Because you are one of the most important surgeons doing intersphincteric resection in Mexico.
Thank you so much, Hugo, and thanks again for your kind invitation. And thanks to all the panelists for these wonderful lectures. I always learn something new from each one of you. I really think it's very valuable what Dr. Kim showed us about the Delphi consensus. I think that you have to touch these very important issues about intersphincteric resections. So I just have some comments. Dr. Maslan put some contraindications for this surgery, which I'm not really sure if they are absolute contraindications or only relative contraindications, which are distant metastases. So now that we have all these biological medications and chemotherapy and these new ways of give TNT to these patients, now we have very good response with this treatment, and we can have these patients with a liver expert, and then, for example, if we have liver metastases that can be resected surgical, and you have a low rectal cancer, I wouldn't say that a contraindication for this surgery. If the patient is doing good and we have reached the goals, that patient will benefit also for the intersphincteric resection. Also, I'm not sure about it. I know it is been exposed in many panels and in many literature about the bad prognostic factors such as pure differentiated tumors. I'm not sure if that's also really a contraindication for the surgery. Maybe that's only the way that the biologic conduct of the tumor, and maybe an APR will result in the same long-term outcomes. So I'm not really sure. For me, the most important thing to do the surgery is to have the oncologic margin, the oncologic resection, like distal margin, circumferential margin. I think that's the key for selecting these patients. Also, I have another comment. For me, we have around maybe more than 200 cases of intrasphincteric resection. I had the honor to be trained in 2014 with Dr. John Marks. So I learned his technique. So if you have the robot, I only have robot for private patients. So my volume is in a public hospital, and we don't have the robot. And do this technique by laparoscopic surgery in this male patient, obese patient with a large prostate, it can be really challenged to get those beautiful images that you shown us from above if you are doing laparoscopic surgery in these kind of patients. So for me, if you don't have the robot, the best approach to do that is to have a very good technique in open intersphincter resection. You mentioned the rectouretral muscle, which I think it's a very important anatomic landmark. You have to know how to differentiate this, to identify the prostate and the rectouretral muscles, to be sure that you won't have an urethral injury, and that you will have the anterior plane free of cancer. So I think you need to know how to do an open approach also. And the TATME, the TA-TME, for me is the best approach for these cases. So when you do the intersphincteric section, I close the rectal stone, and then I start from below with a TA-TME, which sometimes the learning curve is larger than robotics. But if you don't have the robot, I think that's the best approach. And I must say about the robot that it's wonderful. If I have the robot, I mean, if I had the robot in the public hospital, most of my TA-TME, I wouldn't do that. But I have to say that there are some cases in robotic surgery that are also very difficult in these obese patients, that sometimes it is very difficult to reach and to see the rectouretral muscles. And when you go down from below and go to the intersphincter resection, sometimes I just regret I don't have the transanal platform, because it is very difficult still to reach out and connect the dissection made from above, even with the robot. So those are the really difficult cases. And my last comment is that, and I don't know what about the rest of the panel, but with since the pandemic in 2020 that the Rapido trial was introduced, it was very convenient for the public hospital to use short-term radiotherapy with good results with the TNT. But for me, I have found much more difficult to do these intersphincter sections in those patients that were submitted to the Rapido trial. I found out that these planes are much difficult to find, and I think in this particular group of cases, we are having more incomplete mesorectal resections, although we have reached more pathologic complete response, and we are still waiting for the long-term results of these patients, but that's something that is going on with us. So we are trying to shift these patients of low inferior tumor to a standard long-term radiotherapy. So those are my comments, and thank you so much.
Thank you so much, Dr. Vela. If you want to start, Dr. Maslan, with some comment about the questions regarding Dr. Vela.
Yeah, thank you, Dr. Vela. Now, I absolutely agree with you with regards to the relative contraindications for metastatic disease. I mean, if you have an oligo-mets in the liver or in the lung, which is easily resectable, then I don't think you should totally exclude these patients from the benefit of a sphincter-saving surgery. I don't have much experience with a robot, and in my limited experience doing an ISR, It's always with a laparoscopic approach. And I think in a TATME, going down too low, that low, I don't do TATMEs for resections that low down in the pelvis. And obviously the videos that I've shown are tumors that are small, and that I absolutely agree, if you have an obese male with a very narrow pelvis with a huge tumor, then even doing it laparoscopically, trying to identify those structures that you mentioned may be extremely difficult, and having a robot would definitely help. Now, in Malaysia, at least, the role of TNT and short course radiotherapy is only beginning to take traction, and we still generally do long course radiotherapy. So I've not had any experience with ISR in these cases, but I'm thankful for your insight in pointing out the difficult dissections of TNT and short course radiotherapy. Prof. Kim, perhaps you have some insight on this?
Yes. First, I have to tell that I'm very much biased with transabdominal first approach than peranal first approach, because most of my cases of interspinal resection during the past 10-15 years is mostly done by robotic. I have done more than 200, and most of cases robotic intersphincter resection. But I can tell you, if I do not have robot in my practice, my indication or my practice for intersphincter resection might be lower in terms of case volume. Again, I'm very much biased the transabdominal approach. Secondly, my data for risk factor of local recurrence after intersphincter resection, I have two risk factors. One is anterior location. That is, again, as Dr. Vella told us, if the tumor involves in the anterior part of the rectum or low a low rectum, particularly in male, it's very difficult to get a safe radial margin with having a proper plane. Yes, that is definitely same for open laparoscope and even for robot. Transanal, I think it probably same. So the location of the tumor was one risk, and also the lymph node status was also one risk factor. And also another paper demonstrated the size of the tumor is quite matter regarding local recurrence. That paper says if the tumor is larger than 3 centimeters, even after neoadjuvant therapy, is very high risk factor. So considering all these, the size reduction or cyto reduction or downsize or downstage is very important. But at this moment of time, we do not have a very solid data about what neoadjuvant therapy is the best to achieve stage reduction and size reduction as well. We have variety of data regarding the neoadjuvant therapy, TNT, short course, long course, chemotherapy alone. So there are many trials that are ongoing. So after even today, Professor John Marks' last conclusion was we have to consider better neoadjuvant therapy to reduce distant metastasis. That is also related to the type of neoadjuvant therapy as well. So we need more data about that issue. And also, I agree that if we can do curable surgery for metastatic disease, yes, we can also consider intersphincter resection as well.
Okay, thank you so much, Prof. Kim. Mayuha, finally, you want to say something to the speakers regarding your thoughts?
Yeah, thank you so much again, Hugo, for inviting me. I'm actually a very young colorectal surgeon with not much experience, but I have had the opportunity to be proctored by Prof. Kim for a year in 2021 and be involved in his cases of intersphincteric resection. I just have a few questions to Dr. Lukman and Prof. Kim. Number one, to Dr. Lukman. As we are aware, in our country, majority of those cases come with stage 2, 3, and 4, and they're quite advanced stages, and those who actually underwent neoadjuvant treatment would frequently default. So in terms of training during the fellowship of colorectal surgery, would it be better if we have a specific intersphincteric resection curriculum in order for us to be able to provide this and to avoid this defaulting patients? That's number one. And to Prof. Kim Seon Han, I think as a young surgeon embarking on ultra low and intersphincteric resection, I absolutely agree on the transabdominal first approach, as it is the most familiar for us as compared to the transanal anatomy, which can be quite difficult, and it can be a bit scary, especially when we think of the potential complications. So when we talk about, and as you know, that now that you are in Malaysia, robotic is mainly used in the private setting. Okay, for us in the public setting, it is very rare that we are able to use robotic, and you have shown beautiful videos using robotic technique. So my question is, for us who are very much into and willing to perform intersphincteric resection, but we have to do it laparoscopically, what would be your best advice for us to be able to delineate the anatomy and identifying the recto-ureteralis muscle, and also to delineate the limit of the transabdominal anatomy before proceeding with the transanal approach? I think that's all from me.
Okay, I may just answer your question with regards to training. I feel that as a young training colorectal fellow, if you have the opportunity to be exposed to an intersphincteric resection, then that's very good. And I think you should be at least aware of the procedure. Now, but with regards to actually performing it, I feel that for the sake of the patient, obviously the most experienced surgeon should be doing it. But you can obviously assist. Now, because our tumor is generally big and most patients get chemo, neoadjuvant chemoradiotherapy, and then we do repeat the MRI after say 6 to 8 weeks, after about 6 weeks prior to the 8 to 12 weeks window after long course chemoradiotherapy. If there's an excellent response with good preoperative workup based on the MRI after chemoradiotherapy, then, and if these patients are suitable candidates, then obviously offer them ISR, and this should be shown to the trainee. But you know, there are not many, obviously. I think and as you said, in a resource, we're not a entirely resource-rich country. So when it comes to the availability of the robot, it is not like what you said, everywhere. So if you're going to do it laparoscopically, then you probably need to find a suitable patient, you know, female pelvis, perhaps smaller tumors, good response, and then you do that for the, you know, to begin with. Yeah.
Thank you, Maya, for the question. Yes. Yeah, here in Malaysia, the majority of robotic systems are installed in private, and very few teaching public hospitals or educational hospitals have robot, have not have robot yet. So regarding to your question, patient selection might be very important. An obese male patient is not easy by laparoscopy. However, I want to tell you to have knowledge on the low pelvic anatomy is the first priority. That is, I have two anatomic landmarks for intersphincter resection. One is anococcygeal ligament, different name, many different names, rectococcygeal or hiatal ligament. It's all same structures posteriorly. It's about 4 to 5 centimeters from the anal verge in most patients. And anteriorly, recto-urethralis in male and perineal body in female. Of course, if you have only laparoscopy, even during open surgery, very difficult to see that particular anatomy in the anterior part of the rectum, in the very low pelvis. However, if you have knowledge on this anatomy, you can see more and more, even during open, even during your laparoscopy. So knowledge on these two particular anatomy structure is very important. And patient selection at the beginning, in particular, in obese patient, I don't recommend this, but even in male, in thin patient, yes, you can see the anatomy. So that is the way to start to learn this intersphincter resection transabdominally. And of course, transanal approach is another way, but as you told, you need different anatomy and different technique, different learning curve. So these are my answers to your question.
Thank you very much to both Dr. Lukman and Prof. Kim.
Thank you so much. Wonderful closing remarks, Prof. Kim. I'm just have a question. I know that functional outcomes is quite an issue. I would like to ask, in your personal practice, before doing an intersphincter resection, do do you assess the anal function through clinically anal manometry before doing intersphincter resection in those patients who have risk factors for incontinence after the surgery?
Manometry, for example, is a long debate, but personally, I do not use it because the manometry is not much related to the real function. In my current practice, the digital rectal exam, whether the squeezing function is good enough or not, is just enough to assess for anal function, and also to select to exclude any patient for poor anal function. And also, as one Japanese paper demonstrated, the overall anal function between ultra-low and intersphincter resection is quite similar in terms of low anterior resection syndrome. I do not have my own data, but during follow-up on the clinic, the patient is very much similar in terms of anal function, even though the anal fecal incontinence is slightly higher, particularly in the earlier time. But later, that is also very similar between ultra-low and intersphincter resection. So I only exclude the patient who have very weak anal function clinically before the surgery. Otherwise, I do include the patient.
Thank you so much. There is any other question from the panelists or from the audience?
I just wanted to add to the question of Dr. Mayuba about the learning curve in the intersphincteric resection. And I just want to add and to reinforce this statement that you have to know how to do the intersphincteric resection from below with open surgery. That's how was first described by Dr. Gerald Marks. And those first data were done with open surgery. So the key here is to have a good retraction of the canal anal to really identify the dentate line. Then you have to mark it. Then you go through the intersphincteric space. And then you can do this digital dissection of the intersphincteric space. Then if you have a male patient, there is a maneuver that will help you, and you won't see the prostate, but you will touch it. So you will touch the prostate, and then you will hook your finger between your prostate and the rectourethral muscle. And you will do it with both of your fingers until you reach the tip of your both fingers, and you will hook the whole rectourethral muscle. Then you will realize how thick that muscle is in the males. And when you cut it, you will safely cut it because you have your finger in between the prostate and the rectourethral muscle. And when you fully cut that muscle, automatically the rectal anterior wall will fall down and you will have the prostate up. And with a good exposure and with a good retractor, you can follow that plane in open surgery. And then when you go back to the laparoscopic surgery, it will be much easier for you to connect between those planes and to have fully mobilized the rectum. So that technique was described by Gerald Marks, and I had found it very, very useful. And what I said to my residents is that these patients, what they really want is to have the rectum, the anus preserved, the sphincter preserved, the preservation. So it doesn't matter the approach. You can do TATME, you can do laparoscopic, you can do robotic, or you can do fully open the surgery, abdominal and transanal open. But the key point in this is that you know how to preserve the sphincter by the intersphincter resection.
Thank you, Dr. Vela, for the tips and the tricks that you have mentioned just now. It's very helpful. Thank you.
Thank you so much for these wonderful technical tips, Dr. Vela. Dr. Jorge, you have a comment?
Gracias, me ayudas a traducirles de pronto. Una de las razones es que en la mayoría de cirujanos acá no tenemos robot. No todo el mundo maneja perfectamente el TACME. Entonces, el haber hablado en esta discusión del origen del TATA es bastante favorable porque es lo que nos ha ayudado a muchos a manejar no solo el margen distal, sino el cilindro y el margen radial en ese tipo de pacientes. Es por eso que las características de nuestros pacientes, muchos son hombres, pero muchos son obesos, bajos, con pelvis cerradas e inicialmente fueron tumores voluminosos. Entonces, hacer el abordaje perine primero, y tal vez la razón por la cual me invitaste, es que nosotros hacemos mucho perine primero. Y perine primero, por lo que la doctora Isel dijo, uno asegura margen distal, entra el plano interesfintérico y además protege el plano prostático. Y el abordaje, personalmente, en mi caso, muchos años lo hago en prono, que es algo que no mucha gente hace, porque me permite avanzar 6 o 7 centímetros y después al colocar el paciente en la posición supino para el abordaje abdominal, que es laparoscópico, ya se puede continuar con la plataforma o inclusive no se necesita tanto la plataforma porque por perine se puede llegar hasta 6-7 centímetros. Es otro tip técnico que puede ayudar.
Can you hear me? Yes. I think it's a good point of view. Dr. Jorge Lombada, he's talking about that it doesn't matter what kind of approach we have to be sure that the surgical principles are going to be done in the surgery. So he was mentioned about the perineal approach for secure the procedure. So I have a question for Professor Kim. I know that most of your clinical practice you are doing abdominal approach, but did that mention Dr. Vela and from Professor John Marks about TATA? What is your personal what's your personal opinion about first doing the perineal approach to be sure that the oncological margins are clear, and after go for the abdominal? Because we saw in the Delphi consensus that it's much better to do the abdominal in order to see there is the distant metastasis, and after that going for the perineal approach. What do you think about doing first perineal approach in intersphincter resection?
Well, sorry.
Yeah, please go ahead.
I think it's you have to unmute, Dr. Vela, because.
So I also have a bias, as Dr. Kim has it, for the first below and then above, because I learned it from John Marks in 2014. By that time, Dr. John Marks was doing most of his low rectal cancer with TATME, not with robot, because he still had the SI. And for me, as I learned, once again, I have to point this to do the open intersphincter resection, and I found it very easy to do it and very safe when you know how to do it, because yes, it is true. I have had at my first cases, I have had some serious complications. I had a urethral injury. I had a vascular injury, which weren't complications that were usually found in the laparoscopic approach from above. So yes, the learning curve is a little bit higher. So the first tip, or the first thing that I really had to learn when I started my cases was really have a very good intersphincter resection before I put the platform, the transanal platform, and to really well identify the prostate or the vaginal wall in the women, and to have done the posterior aspect of the intersphincter resection at least 3 to 4 centimeters. And then when I have really free the rectal stone, I close it, and then I put the transanal platform. Once I ended with my learning curve, which maybe we never end with that learning curve, but once I start to feel comfortable, maybe it was around 30 to 40 cases, it was a long curve. But when I started to really feel comfortable, I really found this approach really easy. I really feel very comfortable doing the traction, the contraction, to find the planes. And once, and with this new technology, with the fixed pneumoperitoneum, with the proper device energy, and I really believe that these 4 or 6 centimeters of the rectum are much better reached from below, especially in obese male patients. Like, you don't even feel that the patient is obese. You don't have that problem. I don't know how to explain it, but as you are working in a space that doesn't exist, you are creating that space, you really don't feel that you are working with an obese patient. So I usually go up from below until I open the peritoneal reflection, and that's where I end my perineal phase. Now, one thing that we have in our country, in my hospital, is that we don't have to work in teams. I don't have that. I don't have 2 towers of laparoscopy, 2 laparoscopic towers. I don't have 2 energy devices. I don't have 2 surgical teams. That's a lot of money, and we don't have it. So it's a long procedure, because I have to start from below, then I go from above, which is really easy because all I have to do is mobilize the left colon, and then I'm already connected with the planes that I did from below. So the most difficult part of the surgery is done, and it wasn't so hard from below. So that's why I think it is much better to start from below, but there's a learning curve that you have to pass. And I have had some cases that I started from below, and they surprised me when I started from above, and they have carcinomatosis or something that I should have realized before starting from below. Those are only a few cases, but because we studied very well our patients before going to surgery, but you can have that issue when you start from below, and there's no turning back. You have to finish the surgery. So for me, it's been a long journey. I started in 2014, and the first cases were hard. But right now, if I don't have the robot, I don't even think about starting in laparoscopic. I always do my cases from below because I am really comfortable with this approach. And our results, our functional results, our long-term results, and our pathologic results, they speak by themselves. We have good results, even in these difficult, locally advanced rectal cancers treated with chemoradiotherapy upfront.
Besides the surgeon preference based on learning curve on each approach, I can tell you that I have some cases that initially the patient was anticipated to require intersphincter resection, but after a completion of transabdominal dissection down to the actually anus, it was completed by ultra low meaning stapling transection at the very, very low rectum, almost close to the dentate line, was feasible. That was particularly true in female. So the trans-abdominal first approach has definitely that advantage. We can avoid transanal part of the procedure. It saves time. Also, it affects on function. So that is one reason why still I'm continuing trans-abdominal approach first. But of course, I'm very much biased.
Thank you so much. I think we are going to finish this wonderful session. I want to thank you, the Malaysian Society. Thank you so much, Dr. Maslan. It was a really great pleasure, Mayuja, and of course, Professor Kim. Dr. Jorge, I don't know if you have some final remarks.
Muchas gracias, Hugo. Varias cosas importantes. Margen distal asegurado. Ellos lo dijeron en sus charlas. Es muy importante determinar el surco interesfintérico como ítem de estudio pre en las resonancias con los cortes adecuados de resonancia, porque eso va a determinar lo que pase después, inclusive de la neoadjuvancia. Es una técnica selectiva que tiene alteraciones en la función esfinteriana dependiendo del nivel de pérdida del esfínter interno. Obviamente las técnicas robóticas permiten llegar mejor. Por la paroscopía no es fácil ver las imágenes que nos mostraron hoy y es por eso que los abordajes perineales tienen su papel cuando se quiere asegurar un margen distal y hacer una resección de una pieza oncológicamente completa. Y por eso, aunque ya no lo llamemos TATA y lo empezaremos a llamar interesfintérico parcial más TACME después, o TTSS, o la técnica que usted quiera hacer, el abordaje perineal pues tiene un campo en un tipo de cirugía que se decidió preservar parcialmente el mecanismo esfinteriano.
Thank you so much. Thank you so much. Dr. Jorge Santin, do you have any comment?
Well, I just want to say thank you very much to all the participants for your excellent presentations. It's been an honor to have had you, and I think we have learned a lot today. Thank you for sharing your experience with us and also with your knowledge. And I hope we see you again in another webinar or around the world, maybe. And para nuestros participantes que están con nosotros, agradecerles que estuvieron con nosotros el día de hoy. Y no tuvimos muchas preguntas, pero recordarles que pueden hacer preguntas a través del chat de los asistentes. Y queremos invitarlos el próximo mes de febrero a nuestra sesión en conjunto con la Sociedad Venezolana de Coloproctología, con el tema de cáncer de colon derecho. Va a haber un duelo ahí entre dos médicos y habrá participantes de la Sociedad Venezolana junto con los participantes de la Sociedad Mexicana. Y nuevamente muchas gracias a todos y thank you very much, everybody.
Thank you so much.
Thank you.
Thank you for your time.
Thank you, everyone.
Bye-bye.
Thank you. Thank you so much.
Gracias.
Gracias.
Muchas gracias.
Bye bye.
Gracias. Muy bien, Hugo, te salió muy bien.
Gracias, Hugo. Gracias,
Gracias,
Doctor
doctor.
Santin, muy bien. Muchas gracias, doctor Aitzel.
Gracias, gracias por la invitación y pues muy productiva la sesión. Muy buenas
Bastante.
ponencias y muy bueno tener contacto con otras sociedades del mundo. Felicidades.
Muchas gracias.
Gracias, doctor.
Gracias, Jorge Lombana. Muchas gracias por la
No, un gusto.
participación igual.
Un gusto. Un poquito de español, aunque sea.
Hay que meter de todo.
Ándale. No, muchas gracias. Listo. Saludos, amigos.
Gracias.
Bye.
Gracias. Hasta luego.
Voy a...
Entonces, ¿sí?
Voy a esperar porque puse una encuesta. No sé si ya se...
Creo que ya salió.
¿La encuesta?
¿Mm? Sí, se salió
Es
la.
que
No,
no,
no aparece la encuesta.
no tuve... Déjame ver si puedo compartir la pantalla y poner esto. No, no se puede. Para ver si tenemos la próxima vez, ¿sabes qué hay que hacer? Tener lista ¿cómo se llama? La... aquí. Bueno, ahí estás, ¿me ves?
Sí.
Mira, esto, así. No sé si aparece para probarlo, a ver.
Aparece transmisión en vivo,
No se
está
ve nada,
compartiendo
¿no?
la pantalla. Creo que veo su pantalla del iPad.
Ah, pero no ves la foto. ¿Sí la ves la foto? Ahí está.
Ah, ya, ahora sí, ya la veo, ya la veo.
Así. Bueno, pues para los que siguen con nosotros conectados, esta es nuestra sesión para el próximo mes. Los esperamos. Muchas gracias a todos. Gracias, Hugo.
Gracias,
Un
doctor.
abrazote.
Igualmente, hasta luego.
Bye.